Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Garland.
If you have IBS-C, chances are bloating isn't just occasional, it's constant, uncomfortable, and the symptom that bothers you the most. So why does it happen, and why doesn't it go away even when you're treating constipation? Today, we're diving into the real drivers of bloating and IBS-C and what actually helps with Dr. Brian Lacey, a leading gastroenterologist with the Mayo Clinic. Welcome, Dr. Lacey. So happy to have you on the show again.
Wonderful. Well, thank you so much for having me here today. This will be a lot of fun.
Yeah. We're going to just dive right in. So we did a previous episode with your colleague, Dr. Kanjemi, and it covered all the basics of bloating. So we're going to just focus specifically today on IBS-C since it's such a major concern in patients, bloating is in patients that have IBS-C. So why is bloating such a dominant symptom in IBS-C?
It's such a great question. So, we know that IBS is present in about 10% of adult Americans, so a very common problem. And about a third of those patients struggle with symptoms of constipation. More importantly, if we look at the prevalence of bloating, in the last week, 14 to 18% of patients struggle with symptoms of bloating, that gassy sensation, sometimes accompanied by distension, that visible manifestation. And we look at just that one symptom, it significantly affects patients' quality of life. It bothers them at home. It prevents social activities. It may really cause problems at work. People don't want to eat. Some people don't want to travel. And so this frequently coexists with IBS and constipation. As you well know, and as your listeners well know, bloating is not part of the definition of IBS. We focus on the presence of abdominal pain and constipation symptoms. But bloating is just so prevalent, it frequently goes hand in hand with IBS symptoms.
No, that's great as a foundation to really understand because it really plays into how this is treated too. Because if you don't understand what's happening, the manifestation of this, it might be confusing for a patient to understand how to treat it. So before we get into the treatment options, what actually is happening in the gut when patients with IBS-C feel bloated? Like, what does that actually mean?
Yes, and I think it's really good because this will help listeners communicate better with their healthcare providers. So, bloating is a subjective sensation of feeling gas on the inside. Sometimes it's pressure or discomfort. Distension is the physical manifestation where people may say, look, I look like I have a beach ball inside of me, or I'm 3 months or 6 months pregnant. Even men say that, like, I look like I'm 6 months pregnant. So, why does that occur? And I think there are a couple of key reasons. One is we've alluded to, this goes hand in hand with constipation. And for many people, if it's difficult to evacuate stool, it's difficult to evacuate gas. And remember, everybody makes gas in their GI tract, right? Everybody makes some gas in their GI tract every day. Number two, I think you've discussed with other providers in the past that IBS with constipation frequently goes hand in hand with pelvic floor dysfunction. As I explain to my patients, going to the bathroom should be pretty easy. It's actually really complicated. And if the muscles in the pelvic floor are not coordinating in the exact right sequence, you are constipated, but you also have problems evacuating gas. Number three, I'm sure Dr. Kanjemi spoke at length about dietary issues. We won't go into that. We also know that intestinal methanogen overgrowth, IMO, or bacterial overgrowth, can be a culprit for IBS and IBS with constipation. Therefore, that too may be playing a role. And lastly, remember, IBS, as you well know, and as you've counseled your listeners, IBS is a disorder of gut sensation. And so many people have normal amounts of gas, but sense it differently. They sense it at very low levels. It's uncomfortable. And that's what that sensation of bloating is.
Is it caused from motility, delayed motility, or prolonged fermentation in the gut, as we're hearing more and more about this with new research that's come out?
Absolutely. And so the problem is Symptoms of gas and bloating are so nonspecific. We can't say, wow, Mrs. Jones, you're 30 and Caucasian, and your gas is due to slow transit moving slowly through the GI tract. But Mrs. Smith, you're 30 and also Caucasian, and your gas and bloating is due to diet. So these symptoms are so nonspecific, but your point is a good one. So sometimes things are moving slowly through the GI tract, whether the stomach or small bowel or colon, leading to symptoms of gas and bloating. Sometimes that's that pelvic floor problem. They can't evacuate stool, but they also can't evacuate gas. In many patients, it's that problem where they sense normal amounts of gas abnormally as uncomfortable. And lastly, something we didn't touch on, and maybe Dr. Ken Jemmy did in his great podcast with you, is that some patients have this funny abnormal wiring problem where they have normal amounts of gas, but then they distend very quickly after eating. They actually have a wiring problem and a disconnect between the movement of the diaphragm and the muscles of the abdominal wall. That's called abdominophrenic dyssynergia.
Yes, he did mention that, and we had to like double check the spelling so many times because I'd never really heard about it like that. So it was like
Yes.
interesting. So is IBSC really about gas then?
Oh, really about, well, I like that way that's phrased. Is it really about gas? I might say not completely. We know it's about pain, visceral sensation, and we know it's about constipation, but gas is such an overriding problem, and bloating and distension in these patients. It should be, really part of the definition, but again, because it's so nonspecific, we did not include that in the Rome criteria.
Interesting. Can you describe more about visceral hypersensitivity, the heightened sensation? And we're not diminishing a patient's experience here, right, Dr. Lacey? We're so cautious about, making sure that the patient, we're not saying it's in your head, but there is a gut brain connection. And I want you to explain a little bit more about that sensation that may seem worse than it actually is, if that makes sense.
No, really well said and so important. So we know that IBS, irritable bowel syndrome, can develop for a number of reasons, and we know it has a number of underlying pathophysiologic events, meaning abnormal pathology. And it's different in different people. But one unifying trait is that patients with IBS generally sense things differently than other patients who don't have IBS. And it is in their gut to start. And that's the concept of visceral gut hypersensitivity. They sense things differently. So the way I'd like to explain to patients is some people, if you push on their hand or push on their leg, you got to push pretty hard before it's uncomfortable. In other patients, so with IBS, as an example, you would barely touch them or just push them a little bit, and it causes significant discomfort. And that's because, remember, the enteric nervous system, the nervous system of the gut, is full of sensory nerves, millions of sensory nerves. And these nerves just sense things at very low levels, much lower levels than other people. And people sense these sometimes normal things as uncomfortable.
Oh, that makes sense. So why so how directly is constipation driving the bloating? I know we keep going in circles, but I think this is important.
No, it is important. And also, it's important because sometimes treating the constipation doesn't make the bloating better. So, an easy way to think about this is, wow, Dr. Lacey, I'm constipated, I have pain, I have bloating. And my response would be, great, let's treat the constipation with whatever agent you want to use, an over the counter agent such as polyethylene glycol or milk of magnesia, or one of the prescription medications. We can talk about those. And the patient returns in 2 weeks or calls me and says, this is great. Constipation is much better, but I still have some pain and I still have bloating. So, in some patients, treating the constipation resolves the bloating because they go hand in hand. But in other people, you can make them go to the bathroom every day. Constipation goes away, but the bloating remains because it's probably that sensory phenomenon. They are just sensing things differently in their GI tract. And don't forget, too, as Dr. Can Jemmy and you discussed in the past, other things can be going on. It's always nice to have one patient having one problem, and therefore there's one solution, right? But along the way, maybe there are some dietary indiscretions, and they're still taking in some lactose or fructose, or maybe there's gluten sensitivity, or maybe they have underlying bacterial overgrowth or excess methane production, intestinal methanogen overgrowth, that's driving some of their symptoms, and that has to be treated as well. So you can see how complicated it can get.
So complicated, and, we understand why we can see why patients are frustrated. It's such a complex, condition. So let's start going down the path of treatments. What are some of the common mistakes patients make when trying to relieve their IBS-C bloating?
Okay, I think this is a good different way to think about this. And maybe we could label this mistakes we've all made, right? So the
Yeah.
first mistake would be to say that over the counter agents will treat your gas, bloating, and abdominal pain with IBS. So we know, as an example, polyethylene glycol, sold as Miralax and Glycolax. It's safe, it's effective for constipation, but does not help pain. We know that, and will not help bloating. Okay. Showing again that disconnect sometimes between treating the constipation but not improving gas and bloating. Fiber. So we know that 50% of adult Americans are fiber deficient. That can contribute to symptoms of constipation. However, sometimes adding fiber to your diet can help the constipation but make the bloating worse. As an example, a teaspoon, think how small that is,
Yeah.
of fiber can produce 200 cc's of gas. That's nearly a soda can of gas. Wow, right? That's gross.
Wow.
And three, milk of magnesia products, these osmotic agents are frequently used to treat constipation, but once again, won't help the pain of IBS and won't help the bloating. So those are kind of over the counter mistakes that could be made.
Yeah, and it's not even such a mistake as a myth. Like, you think that if you increase your fiber, but then if you do it too fast, you could have, worsening symptoms, and relying on those over the counter. And I've said this before to you. I remember my grandmother continuously like pop in the Correctol and the Senecoc and the milk of magnesia. And, she lived a lot of her time really uncomfortable because she's trying to address. I wish I was doing Gastro Girl back then. I probably could have helped her. But seriously, like the reliance on the over-the-counter products without understanding the mechanism of action or how if it's really addressing your underlying symptom is not, a good thing. And that's why it's so important to talk to your healthcare provider, like you, Dr. Lacey.
Exactly. And again, sometimes those agents can help people with mild constipation, but they won't help the pain or the bloating. And so that's kind of where that level of frustration comes in. Patients will say, wow, I'm taking polyethylene glycol or milk of magnesia and constipation's better, but these other symptoms persist, which should then lead to the provider and the patient saying, okay, what's our next step, right? What are our options?
Yeah. I know we talked about food intolerances or in our previous houses, but I don't want to skip it entirely because we have, as there's what happens, especially with GI patients who have IBS, is they start avoiding and they become very avoidant restrictive in their eating, which causes other issues such as nutritional deficiencies. The way that bloating is presented a lot online and social media, what patients are seeing is it's caused by food and eat this, don't eat that. And it really creates a lot of chaos and confusion and fear for patients. So, can you address the fact that we assume, or maybe some patients assume, that bloating is caused by food and maybe address that a little bit?
Absolutely. And so let's tease that out a little bit more because it is so complicated.
Yeah.
Because as you pointed out early on, yes, in some cases, bloating is caused by food. So we need to take a really good dietary history. However, and before I dig into that a little bit more, all bloating is not due to food. So as an example, we know that lactose intolerance is common in the United States, 35% of adults, and up to 95% in Blacks and some Asian groups. And lactose intolerance can cause bloating. We also know that many people don't absorb fructose normally. We discussed fiber. We discussed some complex carbohydrates, so things that may normally be very healthy for you, cruciferous vegetables and whole grains, those things can ferment in the GI tract and cause gas and bloating. But your point was excellent because somebody could say, wow, I'm having these symptoms. Let me remove dairy first, but symptoms persist. Then let me remove fresh fruits with fructose. Then let me remove whole grains, but I'm still having bloating and gas. And all of a sudden, they're on this very limited diet of, water and white rice and boiled chicken, and they still have gas and bloating because it wasn't the diet. It was the underlying constipation or the visceral hypersensitivity or that funny reflex, that abdominophrenic dyssynergia.
It's so interesting. Now, before we get into the treatments, let's talk a little bit, let's divert a little bit because I think it's important now to bring up your review article or your article that's going to be published. Is that right? It's going to be published in the journal soon. I believe it was published online on bloating.
Right. So thank you. A little highlight there. So in the American Journal of Gastroenterology, I think it's available online this month. We discuss bloating and breath tests, really kind of focusing on the use of breath tests, but also discussing bloating at length. So that might be useful for many of your listeners.
Yeah. So, if someone has IBS-C, do any of those tests apply to them?
So, great question. So, when we think about IBS with constipation, there I might call out maybe two tests. So, remember, we try to make that diagnosis without a lot of testing. So, in the average individual, a good history, looking for those warning signs, a careful exam using the Rome criteria, you can make that diagnosis of IBS correctly 99% of the time. However, as I mentioned, frequently there can be overlap of pelvic floor dysfunction with IBS and constipation, and treating that is with physical therapy. So, identifying that with testing of the pelvic floor, anorectal manometry, and a balloon expulsion test might be useful, but also bacterial overgrowth, SIBO, or intestinal methanogen overgrowth, IMO, can either be the cause of IBS or coexist. And so, in some patients who don't respond to first line or second line therapy, doing that breath test can be very useful. The good news is, in this day and age, if somebody has failed over the counter therapies for their IBS and constipation symptoms, that there are 4 readily available FDA-approved medications for the treatment of IBS with constipation. I think probably many of your listeners are quite familiar. We have lubiprostone, which is approved almost 20 years ago. It's a type 2 chloride channel activator. We have both plecanatide and linaclotide, GCC guanylate cyclase activators, and we also have tenapanor, a sodium hydrogen exchanger isoform 3, which acts through a different mechanism of action. So those medications are FDA approved for the treatment of IBS constipation. Why do I kind of mention this as a group? Because we actually did a study a few years ago looking at those medications and focusing on the response for bloating. Specifically, how do these medications help bloating? Because we know they help IBS with constipation symptoms. And the bottom line is that all of these were effective at also improving bloating. And linaclotide may have been just a little bit better. We didn't have such great data on tenapanor at that time because all the data hadn't been released. But if you failed over-the-counter agents, there are 4 FDA-approved medications for IBS and constipation, and all have been shown to improve symptoms of bloating as well.
Great. And how does a patient know what's right for them? Like, is there something that a doctor starts with and then you move through or through a series? This is what's we always get this question, and I know the different mechanisms of actions, which is huge because it does give patients options.
Yeah, and that's what's kind of frustrating to both patients and providers because I wish we had that crystal ball to say if you're 35 and 6 feet tall and you've had symptoms for this long, clearly drug A will work better than B, C, or D. And we don't have that. We should admit right now we still have a lot to learn about IBS. We know a lot, but we have a lot more to learn. And I wish we had great predictors of response. So, the way I start an approach is to double check first what have they used before. So if they've already used drug A or drug B for a reasonable period of time, 4 to 6 weeks. Don't reinvent the wheel. Use something different. The second thing to think about is sometimes what medication is available through their company. To be honest, sometimes we're driven by what the patient's insurance plan will allow, right? Doesn't do any good to give somebody a prescription if they can't get it filled. The third teaching point, I think, is I generally start at a lower dose. We know that many of these medications come in different doses. Linaclotide is an example, lubiprostone, tenapanor once a day versus twice a day. I generally start kind of at a lower dose once a day to kind of get a feel for how patients respond because it's not always easy to predict what dose they will respond to.
And, if something's not, we talked about this a while ago, I think, is, what is good enough? Do patients have to settle
Mm.
for just good enough? And if their healthcare provider suggests another treatment option, how can we help patients get over the fear of trying something new? That's a huge question that we hear over and over again.
No, it's a great question because we'd all like everybody to be asymptomatic, and that's pretty hard in this condition. And sometimes I use the analogy of back pain, chronic back pain.
Mhm.
Rarely do we just cure it. We're kind of treating the symptoms and we try to get you to a level that's reasonable. So let's take somebody with IBS and constipation and they have bloating. Diet didn't help. They do not have bacterial overgrowth. You give them one of those FDA approved medications. Wow, in the first week or two, constipation is better. And over the next 4 to 6 weeks, abdominal pain gets better, but they still have some pain and bloating. And as an example, that frequently represents that concept of visceral hypersensitivity, what we were talking about kind of at the beginning, that their gut is still sensitive to normal amounts of gas. And in this case, we may use what we call augmentation therapy. Fancy word, but all it means is let's combine something. So if somebody is doing well in terms of their constipation, but still needs some help with their pain or bloating, maybe adding in another medication, kind of layering it on top to treat that visceral hypersensitivity. And I think you've discussed with the other guests before using what we call neuromodulators. Let's dampen those overly sensitive nerves.
Yeah, and for patients that may not realize that the gut has the second largest number of neurons after the brain, correct? So that's why those neuromodulators would be used. It's almost like tweaking that little sensation area, that little hub, which fires those nerves that could create those symptoms, correct?
Absolutely. I tell my patients, you have more nerves in the GI tract than in your spinal cord. In fact, 5 times as many nerves as in the spinal cord. Most of those nerves are sensory in the nature. The gut is a sensory organ.
So that makes sense to use those neuromodulators. And I love hearing that explanation because people are like, I'm not depressed, I'm not anxious. Why am I taking this neuromodulator? And here's exactly why.
Exactly. And we should remind your listeners that the doses we use in GI are not the doses psychiatrists use. We use very low doses, which are very safe because those sensitive nerves don't need those high doses that were used 35 years ago for depression.
That's such great information. I know we're running out of time because you're a very busy healthcare provider. And let's just ask this: when should IBS-C patients worry that bloating is something more serious?
Right. So the good news is usually it does not mean something serious, but there can be that occasional patient where it is a warning sign. So what I'm looking at is a family history of a GI malignancy or a reproductive tract malignancy, such as ovarian cancer or uterine cancer. I'm looking at patients who are losing weight unintentionally. We use about 10% of your body weight. I'm looking at patients who are anemic or also those patients where you're doing your best, the patient's doing their best in terms of following instructions, the provider's doing their best, but something is not right, symptoms are persisting, then further testing should be pursued to try to identify the cause.
Thank you, Dr. Lacey. And then finally, any final big takeaways for patients who may have jumped in or skipped ahead and listening to your words of wisdom here?
Oh, I guess what I would say is when you go to see a provider, come prepared. Let them know about medications and prior tests. Make sure you get to tell your story, right? Make sure you get to discuss treatment options, really form that treatment plan together with your healthcare provider and discuss the risks and benefits of these medications and treatments and diets. And don't give up, because there's usually a solution.
Thank you so much, Dr. Lacey. It's always such a pleasure to have you on the show, and you're such a great explainer of really hard medical terms, and we really appreciate your insight. If you're living with IBS-C and struggling with bloating, you're not alone, and you're not doing anything wrong. This is a complex, real symptom, but the good news is we're finally seeing better understanding and better treatments. For more expert-backed answers and personalized guidance, download the Ask Gastro Girl app, your trusted digestive health guide. Visit the ACG, the American College of Gastroenterology site at gi.org/patients. And check out our other episodes. We have them on bloating and previous episodes that relate food intolerances with IBS. Thank you so much.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.